Thank you everyone for attending this session. My name is Chaelin Kim, and I'm delighted to be here today to talk to you about our findings on global and regional burden of attributable and associated bacterial AMR avertable by vaccination. And this is a modeling study assessing the potential impact of vaccines on bacterial pathogens, as this title describes. To begin with, antimicrobial resistance is a growing global health problem that is causing many deaths and significant economic costs. According to a review commissioned by the UK government, if AMR is not properly controlled, it could cause 10 million AMR-related deaths per year and a cumulative economic loss of $100 trillion by 2050. Also, according to a recent Lancet article that came out from the Global Research on Antimicrobial Resistant Project, which is a GRAM project, 1.27 million deaths were attributable to bacterial AMR, and 4.95 million deaths were associated with bacterial AMR in 2019. So along with other prevention measures such as water hygiene, water sanitation and hygiene, which is wash interventions, vaccination can make a direct impact on the AMR health burden by directly preventing the emergence and transmission of drug resistance and drug sensitive infections and associated antibiotic use. And also vaccination can make an indirect impact as well by reducing resistance infections among the unvaccinated population through herd immunity. And next, vaccine can also prevent infections where antimicrobials are wrongly prescribed, such as primary viral infections, and accordingly it reduces antibiotic misuse and overuse. And lastly, it also reduces the use of antimicrobials to treat secondary bacterial infections caused by viral diseases. So the World Health Organization has recognized the need to capture and quantify the role of vaccines against AMR. So one of the WHO's efforts is to develop the WHO value attribution framework for vaccine against AMR. So when defining the value of vaccines in reducing AMR, there are a number of criteria that could be considered. So the value attribution framework considers the value across 5 different criteria here, including vaccine-averted AMR health burden, vaccine-averted economic burden, vaccine-averted antibiotic use, sense of urgency to develop approaches to contain AMR, and pathogen impact on equity and social justice. So one of the main purpose of our study is to provide evidence for the first criterion on the vaccine-averted AMR health burden. Here we wanted to know what is the number of deaths relevant to resistance pathogens and the proportion of these infections that could be averted by vaccination. And the output of this research will also be used as an input for the second and the third criteria of vaccine-averted economic burden and vaccine-averted antibiotic use. So even though vaccination has a great potential in reducing the burden of AMR, evidence is still limited, especially due to challenges in updating data on the health burden related to AMR in order to estimate the impact. So, but as I mentioned before, the recent Lancet article from the GRAM project estimated the death and DALYs attributable to resistance. They estimated this by replacing all drug resistance infection with susceptible infections, and also estimated the death associated with resistance by replacing all drug resistance infections with no infection. So using this data, we aim to estimate the vaccine-avertable bacterial AMR burden based on the profiles of existing and future vaccines at the global and regional level. So we believe that this will be valuable to inform improvements in the coverage of existing vaccines and prioritize research and funding for new vaccines in the pipeline. So this is a simple description of our methodology. We use a static proportional impact model and estimated the vaccine impact in terms of reduction in age-specific AMR burden estimates for 2019 from the GRAM project data. So we applied it in direct proportional to efficacy, coverage, target population for protection, and duration of protection of existing and potential future vaccines. So we estimated vaccine avertable death and DALYs attributable to and associated with AMR by pathogen, infectious syndrome, and region with 95% uncertainty intervals for 15 bacterial pathogens. So we analyzed the vaccine impact using two different scenarios: the baseline scenario for primary vaccination of specific age groups, and the high potential scenario that include additional age groups at risk. The vaccine profiles consisted of 15 different bacterial pathogens. These were the pathogens that were part of the WHO evaluation of the value of vaccines in preventing AMR. So for vaccines such as vaccines against Haemophilus influenza type B, Streptococcus pneumonia, and Salmonella typhi, our assumption is based on the expanded coverage of these vaccines in order to meet the strategic priority on coverage and equity of Immunization Agenda 2030. So for vaccines that are not available yet, we developed hypothetical profile based on preferred product characteristics, target product profiles, non-attributable of advanced vaccine candidates, and expert consultations with WHO working groups and pathogen experts to make it feasible and more appropriate. So our assumption include vaccine target efficacy, coverage in target group, duration of protection, population, and disease presentation averted to estimate the impact of vaccines across the 15 different pathogens. So this is a table of vaccine profile that we developed. And here we applied the proportion burden reduction based on coverage and efficacy to target population based on the age of immunization, disease presentation that the vaccine targets. So for example, the assumption for the Group A Streptococcus vaccine is that potential future vaccines would target Group A Streptococcus infections with all type of disease presentation with 70% efficacy and 70% coverage. So we estimated with a hypothetical situation that the vaccine were given in the 6th week after the birth and became effective after 2 weeks, so which means that it will be effective from the 8th weeks from the birth. And then we assume that the immunization will last for 5 years. And this is the list of the vaccine profiles. And for the future and hypothetical future vaccines, so here there is a reference. Some of them are based on the hypothetical vaccine based on expert opinion, and then some of them are actually based on the existing vaccines profile. So these are the result. As a result, we estimated that vaccine-associated the 15 different pathogens could avert around 488,000 deaths and around $27 million associated with AMR. And this is one of our main findings. If you look at this graph on the left-hand side, you can see our estimation of the vaccine impact on AMR burden by pathogen. And here the x-axis shows various pathogens and vaccine profile with assumptions applied to conduct the analysis. And the y-axis shows the number of deaths that could be averted. So light blue means the avertable death associated with resistance, and dark blue means the avertable death attributable to resistance. And as an example, on improved vaccine against Streptococcus pneumonia with 50% efficacy against lower respiratory infections and 70% efficacy against the central nerve system and cardiac infection could avert around 124,000 deaths associated with AMR when the vaccine was given to 90% of infants at the age of 6 weeks of life in 2019. And secondly, on improved Mycobacterium tuberculosis vaccine, that is second profiles of the Mycobacterium tuberculosis vaccine from the WHO's preferred product characteristic with the criteria of 80% efficacy would avert around 118,000 deaths in 2019 when given to infants with lifelong immunity or boosting. So lastly, vaccine for Klebsiella pneumonia with 70% efficacy against all disease presentation could have averted around 65,000 deaths associated with resistance when it is given to infant. So, and then if you look at this graph shows the vaccine avertable death and DALYs attributable to and associated with bacterial AMR for the different infectious syndrome in 2019 at the global level. So vaccine avertable mortality associated with bacterial AMR was highest for lower respiratory infections at around 155,000 deaths, followed by tuberculosis at 118,000 deaths, and bloodstream infections at 112,000 deaths in 2019. Next, we also stratified vaccine avertable AMR burden for each infectious syndrome, as you can see in this figure. Streptococcus pneumonia and Staphylococcus aureus, Klebsiella pneumonia account for the greatest vaccine avertable AMR burden associated with lower respiratory infections. And Klebsiella pneumonia, Acinetobacter baumannii, and E. coli account for the greatest vaccine avertable AMR burden associated with bloodstream infection. And lastly, as you can see here from this graph, vaccine avertable death associated with bacterial AMR, avertable burden associated with bacterial AMR, so we're highest in the WHO African region at 161,000 million deaths, followed by WHO Southeast African region at around 153,000 deaths in 2019. So in summary, the AMR burden avertable by vaccination in 2019 was highest for the WHO Africa and Southeast Asian regions for lower respiratory infections and the tuberculosis and bloodstream infection by infectious syndromes, and for Streptococcus pneumonia, Mycobacterium tuberculosis, and Klebsiella pneumonia by pathogen. However, the low vaccine avertable burden associated with AMR does not necessarily imply that vaccines are of low value. So our value indicators such as the impact on antibiotic, so there are other criteria, for instance, the impact on antibiotic use, economic burden, and social equity. So these should be also considered to assess the value of vaccines against AMR altogether. And lastly, AMR causes death and significant health costs. So the vaccine avertable burden of AMR should be factored into the full value of vaccine assessment. So when I say full value of vaccine assessment, I mean that the value of vaccine can be measured across a wide range of criteria other than just mortality. It can include economic consequences, social justice and equity, and many other related impacts, but our study is highlighting that the vaccine avertable AMR should be factored into the full value of vaccine assessment. However, our research should be interpreted with caution due to the limitation of our study. For instance, as we only look at the direct effect of vaccination, we did not really capture the indirect effect and transmission dynamics of AMR pathogen. And next, we only included 15 bacterial pathogens. There could be an impact of vaccine on other bacterial pathogens that we did not take into account in our study. And thirdly, we use the data from GRAM project, and the data, this data also has its own limitation with limited input from low and middle income countries. And next, we did not consider the impact of viral vaccines on reducing antibiotic misuse and overuse, which is also one of the key drivers of AMR. And lastly, we used a single coverage for each vaccine and applied it to the entire target population. So therefore, geographic and socioeconomic clustering of vaccination coverage was not taken into account in our study. And I believe that these are remaining gaps in our evidence that could be addressed in the future studies. Still, our research provides meaningful values about the estimating the potential value of future and current vaccines altogether in reducing the burden of bacterial infections associated with antimicrobials. So firstly, to be specific, existing vaccines such as PCV, hip vaccine, and TCV already have a significant impact on AMR, but our finding shows that it could have even greater impact with increased coverage. And therefore, we highlight the importance of increasing the coverage of existing vaccines and accelerate the introduction of TCV. Especially in the high burden countries. And secondly, efforts can be made to accelerate the approval and licensure of vaccine in late stage clinical development that have the potential to have a greater impact on AMR, such as E. coli, Mycobacterium tuberculosis vaccine. And lastly, for the remaining pathogens with vaccines in the early stages of clinical development or no vaccinations, so no vaccine available, it is critical to improve our biological understanding and the feasibility of developing these vaccines from these pathogens, so especially for pathogens with expected high vaccine avertable burden. And that's it. I appreciate all co-authors for their helpful suggestions, guidance, and input for this study. And the findings of this analysis can be found in our preprint paper. The link is here. And and thank you so much for listening. And I also welcome you to have a look at this article. And if you have any thoughts, please share to my email as well. And thank you. And please share your questions and comments. Thank you.
Thanks very much, Chaelin, for your great work and presentation. So yes, we have some time for questions. And just a reminder, if you have any questions, you can feel free to use the raise hand function or type your questions into the chat window. Just wait a minute or two to see if people are formulating their questions. I don't see that we have any questions. So if not, then we can wrap it up there. And thanks again to our speaker, Chaelin, for an excellent presentation.